This lecture covers the respiratory system and is the last bit of material for exam 2. The functions of the respiratory system include moving air and having gas exchange surfaces, protection from the outside environment, making sounds, and using your sense of smell. The respiratory system is organized in the upper system, which is above the larynx, and from the larynx down, which is the lower system. Notice the spelling of the word larynx. It is not larynx, it is larynx. You have laryngeal areas. Pharynx, we'll get to in just a minute. It's not your pharynx, it is your pharynx. Your respiratory tract consists of the conducting portion, and this is where you're actually conducting air, and it goes from your nose to the terminal bronchioles within your lungs. And then the respiratory portion is all of the respiratory bronchioles, which are the non-cartilage covered areas of tubes that are in your lungs, and all the way down to the alveoli, where you have air-filled pockets. The epithelium of your respiratory system has to allow for the efficient exchange of gas. When we get down to the very ends of the tubes, the alveoli, those walls are very, very thin, less than 1 micrometer in width. The surface area is tremendous. It's about 35 times the surface area of the body. And know that this is all a mucous membrane. So remember, for it to be a membrane, you have to have one epithelial layer and at least one connective tissue layer. And there are mucus glands that are engaged, and all of this mucous membrane lines the conducting portion of the respiratory system. Here in this image, you can see the mucus producing cells and the ciliated, you can see the cilia, columnar epithelium. You can also see goblet cells down here, but don't worry about those at this moment. And remember what we're doing, we are trapping particles within the mucus so that the cilia can beat it out toward the pharynx. Here's an actual photomicrograph of the same thing. You can see the cilia, here are the goblet cells, and here is the ciliated columnar epithelium. The lamina propria is the area that underlies the areolar tissue. There are many, many mucus glands that we are going to find within this tissue, not the lamina propria specifically, and these mucus glands are going to secrete onto the epithelial surface. In the lower portion, there are smooth muscle cells that encircle the lumen of the bronchioles that allow for constriction and dilation. There is a respiratory defense system that consists of filtration. So when you think about the hairs in your nose, they're there for a reason, and that purpose is to remove large particles. We also have alveolar macrophages that are represented only in the alveolar areas, and they are going to be security so that the smaller particles that actually reach the lungs can be phagocytized. Again, we have goblet cells and mucus glands that are going to sweep debris using the mucus escalator, using the mucus escalator to get the particles out of your respiratory system. And so here is a great cartoon of this mucus escalator to get things up here. All right, so this is my least favorite picture in all of the pictures of A&P1 and A&P2. It is a section of a head. It is a frontal section, and it is taken off center. So this is your right eye, and this is your left eye, and we're just going to have to get past that. This is your tongue. This is the base or the root of your tongue. So we're going to go through the anatomy of your respiratory system. So this is your nose in this area right here. This is your vomer. This is your nasal septum. So air is going to enter your respiratory system through your nose. It goes through your nostrils. They're sometimes called your external nares. And the air is then going to enter into what is called the nasal vestibule. If you look down here, this area is the nasal vestibule. You have hairs in the vestibule, and this is that first place where you have the particle filtration system. The nasal cavity itself is divided into the right and left sides by the cartilaginous nasal septum. There are mucus secretions that come from both the paranasal sinuses, and we have tears that are going to clean and moisten that nasal cavity. The superior portion of the nasal cavity is called the olfactory region, and this is where you have your sense of smell. Airflow in your respiratory system goes from the vestibule, which is this space right here, through the superior, inferior, and middle meatuses. And so these are the meatuses right here. These are the areas that they're going to go through. And this is the side view of the conchae. All right, so I'm going to change colors here. You make it blue. This is the side view of the conchae. So here's your superior, middle, and inferior conchae. All right, so here's your superior nasal conchae. Underneath that is the meatus. Here's your middle. Here's the meatus, and here's your inferior with the meatus. The meatus is the space. Those meatuses are passageways that are very narrow, and they produce turbulence of the air that you're breathing in. And the purpose of this is to warm and humidify that air, and also to trap particles. That warmed and humidified air is incredibly important because as it goes to your lungs, it increases the warmth and humidity, but you've started it in your nose. Warmed and humidified air, or oxygen, has a greater connectivity to your red blood cells. So you actually can transport more oxygen if the air is warmed and humidified. So breathing through your mouth bypasses this process of humidifying and warming the air. So if a person is short on oxygen, it's best for them to breathe through their nose, in through their nose, and then out through their mouth. As we go back, the hard palate forms the floor of the nasal cavity. Here is your hard palate right here. The soft palate is posterior to the hard palate, and it's going to divide your nasopharynx from the lower pharynx. So here is your nasopharynx, and here is your lower pharynx down here. The mucosa itself again, warms and humidifies the air, and you need to breathe through your nose and not through your mouth when you're breathing in the incoming air. Your pharynx is a chamber that is shared by both your digestive and your respiratory systems. So you can see that this is your pharyngeal area right here. You have the nasopharynx, which is the upper, nasopharynx, which is the upper portion. It has your pharyngeal tonsils, which you can see right here. It also has the opening to the auditory tube right here. All right, so let's just stop for a minute and talk about your auditory tube. Sometimes it's called your eustachian tubes. If you had tubes put in your ears when you were younger, they were put in, they went in through your mouth, stuck the tubes up through the auditory tube opening, and the whole purpose was to allow drainage from your ears, and if there was ear infections, that would allow for drainage, and the substances that were drained would just enter your digestive system. So what happened to these tubes as you aged? Well, y'all, oftentimes they just fall out and you swallow them. They're tiny. Sometimes, sadly, they actually go the wrong direction. And for some people, they will puncture the eardrum as they're trying to come out. So, but tubes are a good thing, and it saves the hearing of a lot of individuals because consistent chronic infections could lead to hearing loss. The oropharynx is the part that is the middle portion, and it communicates with the oral cavity. Let me move some of my markings here. All right, so here's your oropharynx that is in this area right here. Your laryngopharynx, which is below, which is this area right here, it goes from your hyoid bone, which is right here, to the entrance of the larynx and the esophagus, right? So essentially to right about here. All right, that was your upper respiratory system. Your lower respiratory system, we're going to start with talking about your laryngeal cartilages, the cartilage of your larynx. So the purpose of these cartilages are to keep your foods and liquids that you swallow from entering your respiratory tract. When you swallow, your larynx is elevated, and it allows for the epiglottis, which is this structure right here, to fold back over your glottis, right? So when that happens, you will successfully stop, we hope, food from entering your respiratory system. Your thyroid and cricoid cartilages are going to support and protect the glottis itself, which is the opening, and the entrance to the trachea. All right, so let's talk about your thyroid cartilage first. It's this one right here. It's also known as your Adam's apple. It's made out of hyaline cartilage. Ligaments are going to attach to your epiglottis and to your hyoid bone and to laryngeal cartilages. The cricoid cartilage is directly underneath it. It forms the posterior portion of your larynx, and it articulates with arytenoid cartilages and the very first tracheal cartilage right here. The epiglottis is this one right here, and I don't like that it's colored the same way because it makes you think that it's exactly the same, and it's not. It's elastic cartilage, and the action of hyaline cartilage and elastic cartilage are totally different. Your epiglottis is much better demonstrated by this image right here. It is a softer tissue, it has much more flexibility, and its job is to make sure that we're not allowing food and fluids to actually enter your glottis. So how do we make sound? Is that we have air that passes through the glottis. Here it is open, and here it is closed. You can see that right here. And it vibrates vocal cords, and that allows for you to produce sound waves. This picture is a little bit better in that you can see the softer structure of the cartilage of the epiglottis. And here is your glottis right here. This is called a vocal fold. All right, and so it's the sound that passes through the glottis that vibrates these vocal folds that is going to allow for sound waves. Now we can vary the sound by making more tension or producing or positioning cartilages in different places where we move our thyroid cartilage versus our arytenoid cartilage. If any of you all are voice majors, you know what we're talking about when we say the positioning of the cartilages. Your trachea is also called your windpipe. It goes from the cricoid cartilage right here all the way down to what's called the mediastinum. Right, goes into the mediastinum, and this is where it's going. This is the location of your mediastinum, and it branches into the right and to the left pulmonary bronchi. Right, bronchus is singular, bronchi is plural. You have tracheal cartilages that can vary from 15 to 20 in number. They're C-shaped. They're there to strengthen and protect that cartilage. The opening of the C is in the back of the trachea, and this is where the trachea contacts the esophagus. And so this allows for expansion of the esophagus as necessary. Each one of the tracheal cartilages are connected to by an elastic ligament and the trachealis muscle. Each one of the ends of the C's are connected by the tracheal cartilage. All right, so here is a picture of the C-shaped cartilage. It's in yellow, it's not complete, but there it is right there. And this is the trachealis muscle that I just mentioned that attaches the ends of the C-shaped cartilage. Here is also a good view of your esophagus in reference size to that of your trachea. This is your trachea and this is your esophagus. All right. So your trachea is going to divide at the carina, which is this point right here, into your right and left primary bronchi, right? Or your right bronchus and your left bronchus. The right primary bronchi is larger in diameter than the left one is, and it's going to descend at a steeper angle, and you can see that right here. Each one of them, regardless of which one it is, travels to a groove or the hilus along the medial surface of the lung. So it's going to enter the lung at this area that is called the hilus. And remember, we talked about a hilum or hilus. Hilus is plural. Before, and this is where we're going to have nerves and blood vessels, lymphatics, all of them enter the lungs. We have them in our kidney, where all vessels and nerves and other structures are going to enter the organ at the same place. You have a right and left lung. The right lung is larger. They are found in the right and left pleural cavities. They are considered to be pyramids, all right? So this is the apex, this is the base. The base of each pyramid rests on your diaphragm. So there is a bit of a curvature to each base of each lung. And it's a little easier to see right here, this curvature where the base resides on the diaphragm. The left lung only has 2 lobes. You can see here, 1, 2. The right lung has 3 lobes, 1, 2, and 3. The left lung is separated by, each lobe is separated by the oblique fissure. It is a longer, the length is greater, but it is displaced by the heart. And there is an area here called the cardiac notch. And you can see that cardiac notch right here in the actual picture of the cadaver, right? So here is the cardiac notch. The right lung, again, has 3 lobes. It has a horizontal fissure and it has an oblique fissure, and the liver actually pushes it upward. It is wider. So when you think about the bronchi being bigger on the right side, I think you can see why. It has a greater ability to accept more air. All right. Once we divide the primary bronchies, right? Let me start that again. We have a bronchial tree, and that's formed by the primary bronchi and all their branches. So if you could see everything that is down here, that would be the bronchial tree. So we have those bronchi that are outside of the lungs, and those are the right and left bronchi, the branches that are outside the lung, and then we have the branches that are inside of the lung. So the primary bronchus branches to form the secondary bronchi. So here's one here, and there's one here, and those are called the lobar branches, and each one of those secondary bronchis goes to each lobe. So the left side is going to have 2 secondary bronchs, and the right side would have 3. These secondary bronchs are going to branch to form tertiary bronchs. Here's bronchi. There's one here, one here, one here, for example, here and here, for example. And as you can see, these tertiary bronchi, sometimes they're called segmental, they're going to supply air to what is called a bronchopulmonary segment, right? So this tertiary bronchi branched, and it's going to continue to branch smaller and smaller, but this whole structure here is called a bronchopulmonary segment. As you note, the blue or the cartilage is decreasing as we get further and further down and smaller with the structure. So we get more smooth muscle as we move into the lung and less cartilage. So that means we're dealing with more muscular effects on airway constriction and resistance. If a person has bronchitis, that means they have inflammation of any part of the bronchial walls. Right? And so that inflammation means swelling and fluid, which means constriction, which means difficulty in breathing. The bronchioles, as you can see down here, they have no cartilage, right? Completely devoid of the blue. Therefore, smooth muscle is the main control, which means it's autonomic, and which is going to control the diameter and the airflow and the resistance into the lung. So bronchoconstriction means that we have constricted bronchi, and it is caused by your parasympathetic autonomic nervous system that activates it, and a histamine release if we're having an allergic reaction. Bronchodilation means that we have the opening of the airways, and that's caused by the sympathetic autonomic nervous system, and that reduces resistance. If a person has asthma, they could have excessive stimulation and bronchoconstriction, and that severely restricts airflow. All right, as we move down, these tertiary bronchi are going to branch into multiple bronchioles, right? So here we are. These bronchioles will then branch into terminal bronchioles. That's where we're at right here with the terminal bronchioles, and actually that's what you're seeing right here, all right, when it's blown up. And each tertiary bronchus is going to branch into about 6,500 terminal bronchioles, right? So that's a tremendous number. When we start dealing with these bronchioles and we get down into a pulmonary lobule, that is what we are seeing right here, right? We're dealing with a pulmonary lobule. So these pulmonary lobules, they are supplied their nutrients by pulmonary arteries and veins. And so within each lobule, each terminal bronchiole, which is one of these, is going to branch to form respiratory bronchioles that you can see right here. And those respiratory bronchioles are going to allow for gas exchange to take place within the alveoli, or not within the alveoli, but because of the alveoli. So if a person has pneumonia, they have inflammation of the actual lobules, and so that allows for fluid to leak into each one of the alveoli. So each one of these little grape-like structures is an alveolus. All right, so what you see here are 3 bunches of alveoli made up of multiple individual alveolus, right? So think of the alveolus as a grape, and that we're dealing with bunches of those. But when I tell you to think of it as a grape, please don't think that it's solid on the inside, right? So it's a hollow grape. It's sacks of hollow grapes, or bunches of hollow grapes. And you can see that in this picture. So this is a cross section, right? So we've taken this area, this area right here, Here it is right here, and we've taken this cross section through there, and that's what you're looking at in this image. So this is a cross section of a single alveolus. This is a cross section of a single alveolus, right? So it's a hollow grape. Those respiratory bronchioles that we just talked about are connected to the alveoli or the individual alveolus because of the alveolar ducts. And these ducts end at these alveolar sacs. And so that's what you're looking at here. These are all of these alveolar sacs. So these ducts are common chambers. You can't see any in this picture, but they connect to many alveoli. All right. So I want you to just really, as we get really far down here, I just want you to think about the fact that we are dealing with hollow grapes, tiny little balloons, and they're all interconnected and interacting with each other, but you need to remember that they are hollow. As you can see in this picture up here, we have lots of smooth muscle. That's what these wider pink or red bands are. Many elastic fibers. These are the skinnier blue bands. But then look at all of these capillaries. And that's what I want you to recognize, is that the capillaries are on the outside. So these capillaries that you're seeing on the outside are clear here. They've been cut, right? All of these are the capillaries. So the capillaries surround each alveolus, but they do not go through or enter into individual alveolus or individual alveoli. We really need to make sure that you understand that. And even by looking at this picture, I think that this will help. This is the inside of the empty grape, of the alveolus. This is the capillary on the outside of the alveolus, right, as indicated by the red blood cell that's running through the capillary. All right. The alveoli are made up of what is called alveolar epithelium. This tissue has different types of cells. The epithelial tissue itself is called type 1 cells. So I'm putting an X on a type 1 cell. Here's another type 1 cell. Here's another type 1 cell. Those are the simple squamous epithelial cells that are called alveolar cells, or type 1 alveolar cells. I want you to also notice that you have these free-ranging alveolar macrophages. They're free-ranging in that they're not fixed, they're not attached to a cell wall, but they stay within the alveoli. They don't leave, right? So they're there on patrol to capture anything that they can that shouldn't be there. Sometimes they're called dust cells. Then there is a third type of cell that is called a septal cell, and I'm putting an X on a septal cell, right? These are also called type 2 cells. Septal cells are also called type 2 cells. They produce something called surfactant. So let's go back over here, and I'm going to grab a green pen, and I'm going to put a line right here. This is surfactant. So surfactant is on the inside of each alveolus because this is the alveolar epithelium. Surfactant is produced by the septal cells and is a liquid that is found on the inside, right? So here's the capillary endothelium. Right, here is a red blood cell. So this is the inside of the capillary, inside of the alveolus, and here's where we find surfactant. I'm making a big deal about it because it's a big deal. It's an oily secretion. that has different things, phospholipids and proteins. And the whole purpose behind having surfactant is that it reduces surface tension. All right, so let me give you an example of surfactants and the reduction of surface tension. You deal with surfactants every single day. Dish detergent is a surfactant. Bath soap is a surfactant. Shampoo is a surfactant. So these all reduce surface tensions. So think about dish detergent. Here you are, you didn't want to wash dishes last night, but you had, I don't know, you made homemade spaghetti sauce. And so you just put all of the dishes in the sink, and so you've got this oily film on top that has red spaghetti sauce and all of the olive oil that you use, and it's just floating up there. So instead of sticking your hand in the water, which would gross me out totally, you put a whole bunch of dish detergent in there to try to break up all that oil. Well, what have you done? You've reduced the surface tension, and you break up the oil into much smaller bits. Here's another example. When I was a little girl, I was always the one asking why and how. And so somehow I learned when I was younger, maybe it was my older brother or some cousins or something, that showed me that if there was a rain puddle and there were those bugs that walked across the top of the water, you know, they're called water striders, they can walk on the water. If you put dish detergent in there, guess what? They can't walk on the water anymore, and they fall in and they drown, which is a little twisted. But again, what are we doing? We're breaking the surface tension. Well, surfactant is incredibly important. So I need for you to remember that, and I'm going to talk a little more about it in just a minute. So the respiratory membrane, you can see that it's a thin membrane. This is where gas exchange is going to take place between the alveolar epithelium and the endothelium of the capillary. You have a single layer squamous epithelial lining of the alveolus, endothelial cells in the capillary. There's a fused basal lamina in between, but this is where we're going to have gas exchange. We're going to have oxygen going out and attaching to the red blood cells and carbon dioxide coming in. Right, your lungs are located in two pleural cavities. They're separated by the mediastinum, right? So here's the mediastinum right here. Also, here's your aorta, right? There's your tiny little spinal cord for size, reference size. Here's your esophagus right here, all right? So you have these two pleural cavities. Here's your heart. Here's your right pleural cavity. Here's your left pleural cavity. It's lined with the serous membrane. One more time, serous membrane has two parts to it. It has the parietal and the visceral, and there is a fluid in there that lubricates the space between the two layers. Here is the visceral attached to the organ. Here is the parietal lining the cavity. In order for you to respire, right, if I say you're respiring, we immediately think of the fact that you're breathing. But remember, we have two forms of respiration. We have internal respiration, and that is cellular respiration, where we're using CO2 and glucose or fatty acids to make ATP, right, and give off CO2. That's internal respiration. That's not what we're talking about here. What we're talking about is external respiration. So that's everything that's involved with making sure that you're exchanging O2 and CO2 with the environment. So it includes pulmonary ventilation, that's you actually breathing, the diffusion of the gas across the membranes and the capillaries, and then the transport of that O2 and CO2 between the alveolar capillaries and the capillary beds in your other tissues. So not just exchanging that O2 and CO2, or let's just say O2, so that you can feed we're not just talking about getting it into the capillaries to attach to the blood. We're also talking about allowing that transport between the capillary beds themselves and the other tissues. All right, so when you breathe, remember that you're breathing in, and the pressure on the outside is greater than the pressure on the inside, right? So the pressure on the inside falls, and so the air flows in. When you are going to breathe out, right, you have pressure, because if you'll just sit here and just blow out, you're pushing your ribs and everything. So the pressure on the inside rises, and so it's pushing the air out. I also want you to think about what your diaphragm does. You are using your diaphragm to help push air out here in this image with image D. And when you breathe in, your diaphragm is pushing down, right? So you're allowing the air to flow in. It takes specific muscles to allow for us to inhale. Your diaphragm allows for 75% of normal movement. And I want you to just go back and remember which nerve it is that is part of the control of your diaphragm, and that's your phrenic nerve. Okay, remember that, the cranial nerve? So your external intercostal muscles allow for 25% of normal air movement. So it's those intercostal muscles that are allowing for you to expand and contract your rib cage. Remember, costal means rib. We also have other muscles that assist with this. Your sternocleidomastoid, okay? Think about what you're doing when you inhale. Think about your entire body lifting as you're inhaling. I'm sitting in a chair slouching, so everything moved when I did that, but breathe in, feel that lift. Your sternocleidomastoid, serratus anterior, pectoralis minor, and your scalene muscles are allowing, here's your scalenes right here, for you to do that. When you are exhaling, think about your transversus thoracic muscles. Okay, put your hand on your chest and blow out. Feel your rectus abdominis. You blow out, and you can see that we have other muscles that are going to assist with breathing. So, what happens when you're born? Remember when we talked about the cardiovascular system, I talked about the foramen ovale and the fossa ovalis. And one of the things I said to you is, remember, your lungs are flat. There's no air because you're not using them. So before birth, all of your pulmonary vessels not used, fully collapsed, and your lungs do not have air. But during delivery, you're going to lose connection with the placenta. And when that happens, your O2 levels are going to fall and your CO2 levels are going to rise because you have no way to get O2 and you have no way to get rid of CO2, right? During birth, at birth, you as a newborn have to overcome that surface tension to inflate your brachial tree and your alveoli and take that first breath. Notice I said overcome the force of surface tension. What does it take to do that, y'all? It takes surfactant to be able to do that. So let's just pause right here. Oftentimes you'll hear that when a baby is born early, they'll say the lungs aren't fully formed, it has to stay in the NICU for a bit until the lungs mature a little bit. Well, the lungs haven't matured enough to allow for that production of surfactant or enough surfactant. And so it just takes time for that to happen and for the baby to be able to breathe on its own. Okay, so this next point, the large drop in pressure at the first breath. So let me be extreme here. You're a full-term fetus. You're still in utero, but you're going to be born within 3 hours. And I'm going to be extreme. And let's just say that that fetus has 5 miles of blood vessels. Crazy number, but let's just say that. 5 miles of blood vessels in the entire body. But we've already established that you're not using a portion of those blood vessels because the pulmonary vessels are collapsed. You're not using your lungs. Okay, you or the fetus, which one? They're not using their lungs. And let's say that the baby has 4 quarts of blood. That's an extreme number, but let's just go with it. So you've got 4 quarts of blood traveling over 5 miles before you're born. But you're not really traveling over 5 miles. You're not sending that blood 5 miles because you're not using part of your system. You're not using your pulmonary system. So let's say you have 4 quarts of blood only traveling through 4 miles. Now you take your first breath, or the baby takes its first breath. Now you have 4 quarts of blood traveling over 5 miles. What happens to your blood pressure? Huge drop, because you're trying to send the same amount of fluid over a much greater area. That's because you've pulled that blood into pulmonary circulation. You've got to close the foramen ovale, you've got to close the ductus arteriosus, and you've got to redirect that blood in order to have the full pattern where you're using your full pulmonary system, right? You've already been using your systemic system. That's what happens with that first breath. And then with subsequent breaths, you fully inflate your alveoli. So let's just be very clear with this. At the moment of birth, your alveoli are flat. They have no air. First breath, you still don't have all your air. Subsequent breaths fill the alveoli. I need for you to have a clear understanding of why there is this large drop in pressure and why it takes subsequent breaths and what surfactant is used for. All right, now let's talk about what happens as you age. It's not pretty, but it's the same story. Your elastic tissue deteriorates, just like it does in every other system in your body. So your lungs are not going to be as compliant. You're going to ask them to do all sorts of things, and they're not going to be able to do it. And your vital capacity, the amount of air that you can manage at any one time, is going to deteriorate as well. There's also something that you may not have thought about. You have joints, and arthritis can affect those joints, and those restrict your chest movements, and so your ribs don't like to move the same way. And so you don't have that great expansion that you actually have as you had when you were a younger person. And also emphysema can have an effect. It can affect individuals over 50, depending on what they did. If they were a firefighter or maybe they were exposed to cigarette smoke, they have greater chances of having emphysema. So now I'm going to stand on my soapbox for just a minute, and I want you to look at this figure. So we're looking here at respiratory performance from age 0 to 100. And this is, let me start that again. We're looking at respiratory performance from 0% to 100%. Here we're looking at age, from the age of 25 to 75. And let's just say you never smoked, right? So you're at 100% capacity. Even by the time you're at 50, you're at 90% capacity. Then by the time you're 75, you slow down a little bit, and you're at 75% capacity. That's fine. You're 75 years old. Everything else is slowed down. But let's just say you're a regular smoker at the age of 25, and you continue to smoke. And you're on disability by the time you are, let's say, 70, and then you're dead by the time you're 75. And that's just due to cigarette smoking. If you quit at age 65, you might live to 80. However, most of you are way younger than me. If you choose to quit now, at around age 50, you could possibly live to be close to 90. All right, I'm off my soapbox. Don't smoke.